Now we will discuss the classification of drugs for the peptic acid ulcer disease. We classify these drugs into the 4 different categories. Basically, these drugs perform the 2 roles. Either they increase the mucosal defenses or they decrease the aggressors. The first category is basically those agents that neutralize the HCl, and we have already discussed that HCl is basically aggressor. And these drugs that neutralize HCl are known as antacids. The second category is basically those agents that decrease the secretion of the gastric acid, and gastric acid also aggressor. The third category is those agents that protect the mucosal barrier, and mucosal barrier basically mucosal defenses. And the fourth one is basically those agents that eradicate the Helicobacter pylori, that is a major aggressor. The first category that we will discuss are basically antacids, and we have already discussed that antacids neutralize the HCl. They are used for the acid peptic disorder since a long time, and they remain the mainstay of the treatment until the advent of the H2 receptor antagonist and the proton pump inhibitors. Antacid basically are themselves weak bases, and they include the magnesium hydroxide, aluminum hydroxide, calcium carbonate, sodium bicarbonate. As the antacid are themselves weak bases, so they neutralize acid. They also inhibit the formation of pepsin. How they inhibit the formation of pepsin? They neutralize acid. They do not provide the acidic environment for pepsinogen to convert into pepsin. Bicarbonate basically have the potent neutralizing capacity and they act instantly, but we do not use bicarbonate because of several adverse effects like systemic alkalosis, distension, discomfort, rebound acidity, and sodium overload. Aluminum hydroxide, magnesium hydroxide, it is also known as milk of magnesia, magnesium trisilicate. These are the antacids that used nowadays, but they also have the several side effects like aluminum antacid. They are responsible for the constipation. Magnesium antacid, they are responsible for the osmotic diarrhea. The second category of the antipeptic acid ulcer drugs are basically those agents that decrease the secretion of the gastric acid. They include the proton pump inhibitors and H2 antagonists. First, we will discuss the H2 antagonists that include the cimetidine, ranitidine, famotidine, and nizatidine. These H2 antagonists are basically reversible competitive inhibitor of the H2 receptors, and H2 receptors are present on the parietal cells, and they are responsible for the activation of proton pump, that is a hydrogen potassium ATPase pump, which transport the hydrogen ion out of the cell, and in exchange of the potassium ion, the hydrogen ion combine with the chloride ion in canaliculi and form the HCl. So H2 antagonists, what they do, they inhibit the nocturnal acid secretion, they inhibit the basal secretion while we are sleeping. These H2 antagonists are highly selective and they have no affinity for H1 and H3 receptors. The next are proton pump inhibitors that includes omeprazole, esomeprazole, lansoprazole, pantoprazole, and rabeprazole. They all are similar in their efficacy and the mode of action. The prodrugs are basically omeprazole. They are given in enteric coated granules because they are degraded in acidic medium. What is the mechanism of action of the omeprazole? Basically, they enter in the parietal cells from the blood, and in acidic canaliculi, they become activated. The active form binds with the hydrogen potassium ATPase pump and reversibly inhibit that enzyme. And we have already discussed that hydrogen potassium ATPase pump is responsible for the transport of the hydrogen ion out of the cell in exchange of the potassium ion, and hydrogen ion combined with the chloride ion canaliculi and form HCl. So, with binding with the hydrogen potassium ATPase pump and inhibiting that enzyme, they in turn inhibit the HCl secretion, the gastric acid secretion. The side effect of proton pump inhibitors are basically nausea, headache, constipation, diarrhea, and rash. Next category of the drugs are basically muscarinic antagonists, which includes the prinzapine and telanzapine. The mechanism of action of these drugs, prinzapine and telanzapine, they are the muscarinic antagonist and they act on the muscarinic M1 receptors that are present on the cell body of the intramural cholinergic ganglia. They do not act on an M3 receptor that are present on the parietal cell. They act on an M1 receptor that are present on the cell body of the intramural cholinergic neuron. And what they do there, they block these receptors and they reduce the meal-stimulated HCl secretion. These drugs are not considered as the first choice because they have high incidence for the anticholinergic side effects such as a dry mouth or blood vision, so they're not considered as a first choice of drug. Next, we will discuss about the agent that basically protect the mucosal barrier. They include the colloidal bismuth subsalicylate, sucralfate, and misoprostol. First, we will discuss about the colloidal bismuth subsalicylate. Basically, these drugs bind to the ulcer crater and they coat it and they protect it from the acid and pepsin. They also inhibit the activity of the pepsin, which is an aggressor. They increase the mucus secretion and prostaglandin synthesis, and we have already discussed that mucus is a basically protective covering, and the prostaglandin are basically cytoprotective. They increase the blood flow, they increase the mucus secretion, they directly inhibit the gastric acid secretion. And these colloidal bismuth subsalicylate, these also act as an antibacterial against the H. pylori, that is another aggressor. The next mucosal protective agent is sucralfate. Sucralfate basically become the viscous and tenacious paste in the acidic solution, and they bind with the ulcer or erosion for up to the 6 hours. These drugs also stimulate the prostaglandin secretion. These also stimulate the mucus production and bicarbonate output. The side effect of these drugs is basically constipation. The third drug that acts as an agent for the protective mucosal barrier is a misoprostol. Misoprostol is basically a stable analog of prostaglandin E2. They inhibit the secretion of the gastric acid, they stimulate the secretion of the mucus and bicarbonate. Basically, they inhibit the aggressors and they enhance the protectors. They dilate the blood vessels of the mucous membrane. Misoprostols are only agents that are approved for the prevention of the gastric ulcer that results from the side effect of NSAIDs. Misoprostols are basically contraindicated in pregnancy. Why they are contraindicated? Because they produce the uterine contractions. So they are contraindicated in pregnancy. Another side effect of misoprostol is they cause the diarrhea or abdominal pain. For the eradication of the H. pylori, we give the two type of therapy. One is triple therapy and other one is a quadruple therapies, and these both therapies are for 14 to 21 days. This is a very important question. Triple therapy basically consists of the proton pump inhibitor, clarithromycin 500 mg, and clarithromycin is basically macrolide, amoxicillin 1000 mg or 1 gram, and if the patient is allergic to the amoxicillin, we will replace it with the tetracycline or metronidazole, that is flagyl. If the patient failed triple therapy or there is a problem in the tolerating the clarithromycin, then we go for the quadruple therapy. It is also for the 14 to 21 days. In it, there we give the proton pump inhibitor 2 times a day, metronidazole 500 mg 3 times a day, bismuth subsalicylate 525 mg 4 times a day, and we have already discussed that bismuth subsalicylate is a mucosal protective agent. It forms the physical barrier between the ulcer crater and the acid. And the fourth thing that we give in the quadruple therapy is the tetracycline 500 mg 4 times a day. Please subscribe my channel, like my video and also share it, and also follow my Instagram page, that is Medicine All in One. Thank you.